Hello, doctors, students of homeopathy, and friends of homeopathy. Today is the 1730th day of uninterrupted daily webinar of IFPH. And today our guest is Dr. Shibashish Mukherjee, Assistant Professor, Department of Gynecology and Obstetrics, Pratap Chandra Memorial Homeopathic Hospital and College, Calcutta. And today our topic is role of diagnosis and pathological understanding in our daily clinical practice. Let us welcome Dr. Shibashish Mukherjee, and I welcome you all for the session. Just a minute.
Thank you, Dr. Binduraj. Am I audible?
Yes.
Okay. So first of all, I would like to express my gratitude that thanks to IFPH for giving me this opportunity to discuss or present to you my topic about the role of pathology and the diagnosis in our daily clinical practice. So the very thing is that we all know that should we use this pathology and diagnosis in our clinical practice? Is it really important in our clinical practice? We all know that. Okay, where can I share the screen? I think there's an option. Okay, so the screen visible. I think everyone could follow. So basically, as we study homeopathy, we have been taught that we should learn about the pathology, about the diagnosis, and we should understand all those allied subjects. But we have heard from our seniors sometime now or some here and there, okay, we don't need to be bothered about diagnosing and pathology, but we need to get some important symptoms. We should collect the symptoms and signs from the totality and prescribe. For all practical purpose, for prescription or clinical use, we all have somehow or other, we have a notion that we may not be requiring an in-depth knowledge of pathology or how a pathological understanding behind a disease process, or that the diagnosis is only for the sake of legal procedure, the medico-legal part. So is it so? Or is it like we need it actually? So if we go to Organon, that is a book that we refer for our homeopathy, that's we call the mother book. It says in aphorism, thus I have quoted two aphorisms. Obviously, there are repetitions and more explanation further. In aphorism 3, it is said that it's essential to have the knowledge of the disease indications. That is, we should perceive clearly what is to be cured in a disease. And likewise, preserver of health is one. If he knows the things which deranges the health and cause the disease. So, as we can see, Dr. Hahnemann have described that we should know or we should learn about the cause of the disease or the probable exciting cause of the disease. Again, on contrary, in aphorism 1 footnote, if we look at that, we find that we shouldn't be bothered about the internal nature of the vital process or the mode in which a disease originates. Or we shouldn't go on attempting to give countless explanations regarding the phenomenon in which a disease or the proximate cause. So in one hand, Hahnemann is saying we should go for the cause. As we believe today in modern medicine, that disease is caused more or less either due to some pathogen, mostly for those acute diseases and for some chronic diseases, and for others diseases, we do have some other factors. So somehow there has something physical to do with it, something or like that. So is it so that we should be bothered about all those things, or we shouldn't be bothered about these things? That's all, it's our mind. So we should remember that what Hahnemann have said, it is in context of his time. And with time, our knowledge of pathology, pathological understanding pathogenesis, the knowledge of pathogenesis has evolved. But again, as our mother book says, the question arises, should we pay importance to it, or we shouldn't be bothered about it? So let's see that whether it's important to know about the pathological basis, and should we go after diagnosis, or we shouldn't. So why is it today's our colleges, our educational system emphasizing on this thing? So is it essential? As I have told earlier, first of all, that today the patients we face, we mostly what we see, the patient comes to us with a diagnosis or some preconceived idea from their mind. Okay, I have headache, so I may have a migraine, I could have this. Okay, am I going to have a CVA soon? Am I having this? Am I having that? Something that's far-fetched. So what basically happens, you have something, you go for the Google, you search for something, and the patient comes to you and he or she needs the affirmation from a doctor. Probably you are sitting in a test or an examination every single time you face a patient, whether the doctor knows this thing or not. So in our clinical practice, first of all, we need to satisfy these things. Then again comes the medico-legal aspect. Like, okay, if we don't raise the diagnosis, if we don't go for these things, if we don't go for these classifications for ICDs, it has some medico-legal implications. And as I have learned recently, homeopathy is now also coming under the terms of health insurance. And for that, it is quite essential that you give this service. The diagnosis has become quite essential. Again, if you are talking about anything and not writing it, it do have some medico-legal issues. But again, the medico-legal issues, all those things, these are not at all bothering us in a clinical scenario, that is a prescribing or healing. So the third thing that probably concerns us is the prognosis and the line of the disease. That is what we should expect from a case of a disease. Suppose a patient comes to us in our clinic or visit with us with some complaint, and now we have to assess what is the course of the disease. If we don't know what is happening, what could be a good sign, what could be a bad sign, what's going to happen to us, whether we should be considering as a good thing or a bad thing, we won't be able to grasp that things. As we know, or we mostly use, we say that we use Kent's 12 observation. So how are we to know whether this symptoms is from a medicinal aggravation or from a disease aggravation? If we do not have an idea about that this is the natural course of the disease. Suppose we have a situation, obviously for a gastric ulcer perforation, obviously it won't be coming to you in most of the times. But as we can know that there comes a phase where the patient becomes symptomless, which if we do not have an idea that it's a peritonitis is going to set in and it's just something like soon the patient is going to succumb, we would be going into a false idea. Or suppose in a cases where we face a disease, if we do not have what would happen or prognosis, suppose a patient of osteoarthritis, we all must have faced cases of osteoarthritis coming to us with a knee pain. So we should have a clear idea of what we can do. An orthopedic surgeon or an orthopedic would advise a knee replacement. Take an X-ray and you would be finding that if the degenerative changes have set in, we cannot expect to change the X-ray. But what we can do, we can alleviate the pain. We can improve the quality of the life of the patient. So if we just promise that, okay, you have this osteoarthritis, you have a grade 3 osteoarthritis, and I am going to cure it completely, look, this is your X-ray and I'm going to cure it. I'm sorry to say, or I haven't come across anyone who could have reverted that changes. Yes, the patient has a significantly improved quality of life. He or she would be feeling pain only on some rare occasions, but the osteophytic changes, the degenerative change, I'm sorry to say, it's irreversible. So we have to have a clear idea what we are going to expect from the case. If we are expecting that these degenerative changes are going to revert back, probably we are living on a daydream or something like that. So we should have a clear idea and communicate with the patient that, okay, this is your idea, this thing which can be achieved with the treatment. And without this, I cannot, this thing, you do, please don't expect these things that you would have a knee just like an 18-year-old guy. You are now 60 or 70, you will have these degenerative changes. What we can do, we can alleviate the pain, we can slow down the process, but it cannot be reverted back. So we should have a clear idea about it. And in that way, we can face the patient and explain these things to the patient. And it itself builds a trust. I have, in my clinical experience, I have faced a patient, a certain patient came to me. And the patient has an herniation in the inguinal region and about the abdomen. And the first side, I can first understand that whether it's this swelling of, is the abdomen, is a fatty abdomen, it has accumulated fat, and it's the abdomen or just the herniation. It was so large, it's more than the size of a football, because she had that repeated 3 or 4 surgery. Now, if I expect that I am going to cure that hernia with medicine, is it possible? Probably it's not possible, because whatever we do, the patient has only probably one more chance of a surgery, and in that has to be repaired. So I have to advise that patient. So I took my time, I advised the patient, look, it's beyond my domain, I can't help you. And the patient replied that, sir, I have been to many homeopaths, all of 2 or 3 homeopaths, they all claimed they would cure me, and then I took medicine for 5-6 months and things got worse. And when I go to the surgeon, he just shouted at me and said, why do you go for those quacks? And you are the person who is giving me this proper advice. So what happened? This patient would be now trusting me. It's simple way. Probably he won't be consulting me for that problem, but whenever he would be having or she would be having some problem, she would be at least referring me or consulting me, doctor, you are going to give me a proper advice. So in clinic, we know if what is beyond our domain, we should acknowledge that we can't do it. And what's within our domain, we should acknowledge. And how we know what's within our domain, what can be done and what can't be done. If we cannot diagnose the case, that what's wrong with this, the idea of what has gone wrong. So if I haven't understood that this is due to the surgery, some weakness has developed in her abdomen, and all the abdominal content are now coming out or pushing out of that weakness and is appearing like a bulge in front of the abdomen. So we should have the general idea that what's going wrong and what's within our domain and what can we cure and what we can't do. Now, that goes for the prognosis and our line of improvement. Again, for a patient, as important is our medicinal management, there is also some auxiliary and non-medicinal management like diet, regimen, and all these things. Say a patient, we all face patients having diabetes. We all see patients who have hypertension. And most of us miserably fail. We have some success because they come pretty late. We all fail. If they come early, some of us do have some success, but whatsoever. Now for this patient, we should take into consideration that this patient, if the patient is diabetic, and we have to control their diet, so in a way that they don't get the source of elevated blood sugar level, some carbohydrate which has a high glycemic index, or which release their glucose or the sugar content pretty soon. Suppose what we have a common sugar, or we have, say, the patient's having potato or this excess of rice or this, what do, they would increase or they would just surge in the blood pressure level, and this is going to harm the patient. So we should have a clear idea that what the patient is having. Suppose we don't have an idea, often we see that patients who have such problems, we often see a patient having recurrent boils. Everyone must have seen the patient is coming with a recurring boils or a non-healing ulcers. They have developed an ulcer and it's not healing. So if we do not have an idea that what could be the probable cause, we all have injury, we all have ulcers. I am not talking about the internal ulcers, just let's consider some external ulcers, simple cut. We do all have sometime or other time in our life, we all have some or other cut, and it heals due course of time without much complications. Now, someone who having this diabetes will have problem healing. Someone who has diabetes will not be having his recurrent boils. The patient will be having recurrent boils one after another. And until we have the idea that probably the blood sugar could be elevated, howsoever we treat, if we do not have the idea that's what's happening in the background, probably we won't be able to cure the patient or give that patient that proper management. So it becomes quite essential that we have an idea that what could be the probable cause. Just as we have discussed earlier, that we shouldn't be have an idea about what is to be cured in the disease. If we are addressing the boil, the skin boils, that ulcer that's not healing, the ulcer, is it going to heal up by itself? Probably it's not going to be healing up, or the boil would heal up, the ulcer would dry up, and again there would be chances of an ulcer. But now we address this condition, this patient have this diabetes. We advise the patient, we use our medicines with it, or when our medicine fails, we take help of our other pathies, or with our medicines, we manage the blood sugar level. And just after that, we would have a much easier way of healing. Probably we won't have these boils recurring. The ulcers, which was not healing, is going to heal. So it was a time when I was doing my MD. I faced a patient. A patient came to me with a much of an ulcer in a foot. So I would rather say it's somewhat of a diabetic gangrene, non-diabetic patient, high blood sugar level. He had been to the hospital, consulted some physician, and he had put him on oral medication. And the oral medication, what had been given to him was quite appropriate. But what that senior teacher or that senior person failed to realize, that along with that oral therapy, one should address the diabetes. And along with it, since it's a gangrene, one should consider dressing of that part. If we consider that there is a gangrene and it's just biting it and growing deeper in your tissues, and if we are not bothered about cleaning and dressing that part regularly, if we are do not bothered about bringing up the healing tissues, the granulation tissues, or scrubbing those dead tissues off, it won't heal. So when the patient came to my OPD, it has spread pretty further. It was smelling awful. So what we did is we just prescribed just a few doses of homeopathic medicine. I forgot it was whether I had prescribed him sulfur or arsenic, which came first and which was the second. So probably there was We have treated him for say 3-4 months. The ulcer had healed up, but we have used the 3 or 4 doses of medicine, and rest was the placebo. But what we continue to do is we have just added the clinic and dressing. We have addressed the diabetes. And within 3 to 4 months, that gangrene had healed. So we should have the clear idea of what is to be cured in the disease. Because in that disease, what we had to address were basically 2 things. We have to control the diabetes and have to remove that debris. So if you don't have the idea that this debris has to be removed, the dead tissues has to be removed, granulation tissues have to be exposed, and when we see the granulation tissues and the fresh end of the blood vessels or the bleeding tissues, we shouldn't go further off and scrap that off. We should have a clear idea. If we don't have an idea, we would also either would be over enthusiastic and scrap this whole thing up, and it won't be healing. And if we do not have an idea, we would have not gone for this cleaning and dressing. So these are basic, simple things that we can do. It's just a small step, and the healing have ensured. And the patient have been there for 6-8 months, and that disease has been worsening. What I have introduced is just cleaning and dressing and address the diabetes. The medicine that I had given was not very different from what the previous doctor had prescribed. So this small thing, this small idea, what is wrong, what has been this pathology behind this thing, what could the pathogenesis, had given me that extra edge. So in clinic, if we want to have that thing that if we have just implement these small things, we can improve our success rate by quite a percentage, about 15, 20, 30, 40% edge we can easily have with that. Now, the big elephant in the room where we get confused whether we need the idea of pathology or not for selection of the remedy and the management. This is where the most debate starts. We all know that for the management, we need to know about those diagnoses. For the medical legal part, we have all learned that for the prognosis, it's pretty important that we should know the pathogenesis, the pathology. But what about the selection of remedy? Should we need the understanding of pathology? So let's say our patient, we often face patient who feels tired, weak, and frustrated. We all do. And we have a lots of medicine for this tired and frustrated. Now, if we do not have the idea that what is causing this frustration, probably we won't be addressing the patient. Probably the patient is anemic. Probably the patient is not being able to assimilate the food he's taking. There's some assimilation defect could be there. There could be some kind of an pallor or anemia due to chronic diseases. Some diseases have been there. So if we look at our medical, if we look at a pathology, we find a very common rubric that is ailment from or never been well since. So if we have to use this never been well since, how are we going to use it if we do not have an idea like what has happened to the patient? We simply say it's a weakness, it's a prostration. Okay, let's give this and this, and let's give, okay, you have this, you have that, you are having this, you are having that. We would be going haywire. But when we have an idea that, okay, this is the part we need to address. Patient is having assimilation defect, or the patient is having some amount of bleeding. Undetectable bleeding could be the cause. Suppose the patient is suffering from worm infestation. If this do happens, or the patient may be having some focal blood in the stool due to some kind of an ulceration inside the patient. and the patient may not have paid attention to it. So we should have an idea what is to be given in this and how are we to manage a case. A patient having an assimilation defect, probably he may require some medicine which have the assimilation defect like calcaria or sulfur. Or the patient who does have this bleeding per rectum may be requiring this medicines like nitric acid. How are we going to differentiate it? A patient having a soft stool, patient having a regular evacuation of blood, bowel, but having some occult blood loss. And the patient is feeling prostrated. And if we do not go one step ahead that this could be the probable cause, we won't be able to point our questions. Okay, this is the thing, whether you are having this problem, are you having this kind of a stool, or if you are having this problem, this prostration, let's look for some other signs. If it's due to iron deficiency, whether there is some nail changes, whether there is some other signs, whether the patient is having frequent oral ulcers, gum ulceration, we can always look for those things. Or advise the patient, look, okay, please do have this examination done. So this helps in a selection of a remedy. So while I was in my OPD, just probably it's 7 or 8 months back, a patient came to me. Obviously, this patient came to me that he is complaining. He had some burning during defecation. Some burning pain in the abdomen is there. And when I examined him clinically, he's having a severe pallor and a burning in abdomen or the stomach region, which was somewhat I felt tender. And the severe pallor was there. On further inquiry, I found the patient is having this irregular diet. He's just in some business, he gets up in the morning, he say around 3 a.m., goes out for business, spends his almost whole day, returns home, have his food, and when he's outside, he mainly spends his day on tea and a biscuit or two. So it was, and the idea was that what all this can lead to is simple gastric ulcer. Now, this could lead to gastric ulcer or some dyspepsia, dyspeptic condition. Now this patient is having pain in the abdomen, burning pain. So now what I have to do is I have to venture out for that cause, that whether this could be some gastric ulcer is there, or it's simple dyspepsia is there, or it's some colic due to some other reason. So that's how we have to approach the case. So when I asked him, okay, do one thing, you get these tests done, go to some hospital, get your blood test done, and also go and consult the gastroenterologist. I am suspecting these things. Probably you are having this problem. When the patient came back to me, and I advised him that don't take any other medicine. Whatever you do, you just get your investigations done. They would be referring you, you'll be getting it for almost for no charges or free. So don't worry about the money. You just go to the hospital, make some ticket in the government hospital, get these tests done, and come back to me. They're sure going to advise you, this is the test which I need to do. So the patient returned to me, hemoglobin level was 6, and the patient, they have found that the abdomen was, and they have done exactly that it has been diagnosed with a gastric ulcer. So that was evident from the cause the patient is having a gastric ulceration, gastric ulcer bleed, which would have led to this drop in the hemoglobin, this burning pain, this prostration, and all the things. So what was my prescription? I go on and has prescribed a few doses of this irregular life. For this irregular life, I prescribed a few doses of Nux vomica And I was pretty sure that this is going to correct, provided the patient follows some proper diet and regimen. He would be not requiring any blood transfusions. I was confident that it had been an event, and probably if I can monitor him and get his repeated blood tests done in a week or two, that should give me a clear idea that we may not need to hurry for a blood transfusion or something, even if it's the hemoglobin level was just 6. So that gave me that confidence that, okay, this could be the cause, this could be something that we have gone wrong. And I can be confident that the patient is, as soon as it is being addressed, the patient is going to become normal. And now, if I haven't gone after the cause, that it has been due to just an event due to gastric ulcer, but due to some other problem, and a blood, say it's due to some assimilation disorder, the blood level, the hemoglobin level is 6 mg/cent. Probably if it's due to assimilation disorder or something, then we would be probably be thinking of a blood transfusion, because it's not going to be resolved within a very short time, and it would be need some time before the things become normal, before our medicine can come into play and improve this condition. So this management gave me the idea. When I have the idea that this pathology is there in this GI tract, probably due to hypersecretions of the acids, because the patient is doing all those things, the patient is probably having an increased vagal stimulation. Patient probably is going through these phases of anxiety. And as I have cross-questioned him, that, okay, do you have this thing? He said, yes, I do have. I am now being irritated. Now I am irritated, like I haven't been this irritated person, this angry person 2-3 years back. But now I am always irritated. I am always in this kind of thing. So this verified this patient have all those things in a cause. So we move from the effect, and what could be all the things, the probable exciting cause, what are the maintaining cause, we can traverse back the way and go back through our Medica. We exactly have the same picture. For an Vomica, which I have prescribed, it's obviously applying for a patient or a person, but he is prone to night watching, he's prone to those anxiety and anger bouts. The patient who is with irregular life, living on those addictives, the alcohols and all those things, or probably tea in some situations. Obviously, the tea in Indian context is not something in a European context at that moment. We do have the complaint from tea in puja, but that's a different angles. So now, considering the patient is in this profession, having alcohol is a taboo, he won't be comfortable revealing it to me on the first visit. But again, he confirmed that he had been addicted to alcohol, having twice or thrice, sometimes 4 times a week, he used to have alcohol. And now that has been reduced. So all these things happened over a period of within a month. He revealed all those things. So the point is, if you have an idea that this problem could have been happening due to this reason, it gives us the medicine. It tells you what could be the diet, what could be the regimen, what he needs to change in his life, and the cure would be rapid, because the patient's hemoglobin level shoot up close to about 9 or 10 within just 7 days. It was within 7 days that a patient has a hemoglobin level probably close to 9. So if we have an idea, it tells us in a way the management, the prognosis, and the remedy, as in this case. Say if we have the case for nervous vomitor. Now we have that in cases, suppose a patient comes to you with a headache. A patient having a throbbing headache, what could be the remedy? What could be the condition? What should we do in headache if we do realize that what has been the cause? If it has been to sudden exposure to sun, probably we would go for something like a sanguinaria, or if it has a chronic sensitivity to the sun, we could probably think of natriuretic. Obviously, we need to confirm it with other symptoms, but that gives you a preliminary idea that what we should be considering or where we should be focusing. In contrast, a patient who have suddenly on a summer day, who have gone out, got wet, and is having and down with a headache, we may think of a person who have been in a room and then suddenly there have been some load shedding or the current has gone off. He had perspired, and after that, he had developed a headache. Probably we may think in course of time, probably we may think of something like a bryonia or some other remedy. So that's where our idea from the causation, it again goes in the idea of pathogenesis. What could be done and why should our remedy be targeted? Now, in case a patient comes to us, we often do have patients or children who come to us with their running nose, fevers, and sneezing, and often with a sore throat. And sometimes we do face patients who is coming to us having all those things, but no pain in throat. And now in this case, what we do, the medicine would differ. If he's having all those things, having those pain, the one child who is having a pain, we may think of belladonna, Hepacil. While for the painless sore throat, all the signs of inflammation minus pain, that is having fever, the swelling, accumulation of pus, the better option would be Baptisia. So that's how, if you have an idea that where the pathology lies, it gives us an idea what is the uncommon and peculiar thing in this remedy, this condition. If we do not have an idea that what we study, we should have this uncommon, peculiar symptoms, characteristic symptoms and all. So what is characteristics in this case? The characteristic lies which does not fit in this diagnosed condition. A painless sore throat, we would be thinking of Baptisia. So that's where the peculiarity lies. That's where the magic of this idea of this pathology lies. Now moving ahead, what else we have to know? Selection of the potency, whether I should give a remedy in 30, 200, 1M, or should we go for even lower or 6 potency or mother tincture? What should we do? As per the clause, Stuart clause, a selection of potency depends on 5 things. Susceptibility of the patient, that has to do with the susceptibility of the patient and not with, obviously the patient, the disease that affects the patient depends on susceptibility, but for the patient part, we won't be going for much of the diagnosis. But what about the seat of the disease? The intensity of the disease, stage and duration. And what about all these things? The previous treatment is a separate part. We do not need a pathological knowledge of pathology for previous treatment, but rather we should inquire the patient and have an idea. But what about this thing, the seat of the disease? What disease the patient is having? Even with our similar symptoms, depending on the seat, whether it's a disease whose manifestation is located on the skin, or whether it's in the joint or in some other parts, some inner part, that changes the potency, whether it's in a mind or in a finer aspect, we'd be going for a higher potency. If a nature and the intensity of a disease has progressed to an extent that a patient's part or the patient's vitality have been compromised, we see the patient's reactivity is reduced. Probably our choice of potential should be a somewhat a lower potency. Probably a repetition would be needed, where a constant stimulation would be a better option. Or the stage and duration in an acute case, we can think of a much faster action or a faster remedy when it is the space of the disease is fast. But what if the pace is slow? We have to match that thing. Our potency should be likewise. A patient having an acute headache probably would be better off with a Belladonna 30 in a repeated dose. But a patient with, when we have to have this headache in a chronic nature, we have to address it with a remedy bit deeper than that. Something close to Nitrosamine 200 or 1M should fit, where we can have the stage or the duration. A patient suffering from this acute pain, acute headache, probably would require some remedy which would fit in those in a potency that can act on this shorter duration. While for a deeper remedy, which provided it's on a finer organ and haven't compromised those inner balance or the vitality is not compromised, we can think of a higher potency. And now this pathology has progressed. Vitality is compromised. Say a patient having a malignant condition. In this case, can we think of a very high potency? Probably not. Because the disease has advanced to a stage where giving a high potency would bring a reaction so vigorous that the patient may succumb to that condition. So that's where our knowledge of the pathology comes in. If we do have an idea of the pathology, we can cure the disease. Say a patient comes to you with a complaint of pain in abdomen, which on investigation was found to be due to some renal calculi. Now the patient is having a staghorn calculus. Obviously, what happens? It's basically the calculus has taken the shape, is quite large. Usually before it gets detected or create a symptoms, it's usually for a staghorn calculus. It usually happens to be quite large, occupied almost the shape of the pin. And we can't expect that a medicine would clear it. A ureter, if we do have an idea patient, ureter would be like 3 to 5 millimeters. Now we have a stone, say of a 5 millimeter diameter. It's quite easy that it would pass off. A 3 millimeter stone, probably it won't be requiring a medicine. It has a 7, 8 millimeter. It can pass with a medicine. Now we have something like 18 millimeter stones. Would it pass with a medicine? It's highly unlikely. Obviously, we have seen reported some cases where 20, 22 millimeter stones have came out, but we cannot expect that now and then every day are 22, 25 millimeter stones coming out of a 3 or 5 millimeter passage itself. So that's a rare occurrence. So we cannot go for that. Now a patient having a renal stone, what we should know along with water, we have to think of something which would increase the normal peristaltic function. So we need a repetition and probably a lower potency could fit in. Or as we have the cases of some physicians who would give a single drug dose of a higher potency. We have record of both those things and we have to choose either way. We can't mix those things up. So it's all we have to decide what is to be done should be based on the sound knowledge of what is wrong, the diagnosis. Obviously, as Hahnemann has said, that we shouldn't be banging our head in the wall that we need this diagnosis, without it, we are going blind. We probably know that a patient is having a COVID-19 patient. We somehow, knowing or unknowing, many of us have faced that case. Obviously, we all have faced those cases, and it has presented with us something almost just like an flu or influenza. Now, before, in early days, many of those things were without diagnosis also. So, diagnosis, what we have done, we have provisionally diagnosed it. But do we need to search for what the COVID-19 is doing and all those things? Probably we can be a better option. If we can find that, it's very good. If we are laid in a condition where we are blank, we should at least have some idea that what the pathogenesis could be. If we have the idea that this thing, what is done is it's affecting your lung parenchyma. And yes, that all that we have heard that this complaint has been due to most of the complications which we have earned, and the fatality now has been admitted in some journals. Obviously, from the modern school, that the complications are more from the treatment than from the disease itself or the wrong use of medicine, because none know. And they were just like blindfolded. We do had an option. And then we do have our limitations also. But the main idea is we should have some idea that what is going wrong and what is the problem that we are facing and why is it so. We shouldn't be bothered that whether it's this H. pylori, whether the patient has an acid reflux because this it's H. pylori, or is due to some other bacteria or something. But we should have an idea that this condition occurs with this pathology. This pathology, we have this parameter is elevated. If we can detect this H. pylori in a, sorry, I now remember it was the case which I have discussed about those just a few moments earlier, that there has been the case of this gastric ulcer. That what was done, the AFB, they have found that H. pylori is positive by the India first test. I just couldn't recall that test. So if you are, so they had done this rapid urea first test, and they have found that it was positive. So that's the idea, that we should have an idea of what the pathology or the diagnosis is, without hammering our head for the every nitty-gritty, but have a general idea about what is wrong and what is to be cured in the disease. So thank you. So now I'd be like to ask you if anyone do have any questions. I'd be open to the questions.
Thank you, Doctor. And it's the time for asking questions. Let's interact with the speaker. You can raise your hand. So it is a great session, Doctor. So we are getting a better aid if we know more about these pathological things behind the disease, isn't it? Otherwise, it will be very difficult, because what not to do or what shouldn't be done, we need to know. Otherwise, by aiding, we can get some magical results by applying the symptom similarity. We need to minus the whole case we are being taken, and we need to minus these pathological symptoms also, these common symptoms which we need to minus, and we need to find the rare peculiars. The generals we need to elicit by only by studying, knowing what is behind the disease. Only we can acquire this knowledge, isn't it, doctor?
Exactly. But we need to find that what is peculiar in the disease. We need to minus the common symptoms. Plus, when we go for a meta medica, if we do study, they do reflect some disease pattern, the natural history of the disease. This is happening, this is happening, this is happening. Today we go for the keynote material, and we can probably, we may not have that in sequence, but we can trace the condition of a disease, just as I have explained in case of that gastric ulcer patient. It was basically what was written in our Allen's keynote. Simple. One after other, just we have to match those things. And then for a case that, just as I have described in case of bacteria, so that painlessness was the characteristics. So we need to have an idea of the pathology to understand. First of all, what we do, we have to match the conceptual picture of the disease with the simillimum drug image. For that, we also need to have this pathology. When we have the idea of development of the disease and that disease process of the natural history that the drug is a simillimum to, that helps us in simillimum. In a way, also finding the peculiarities, the nitty-gritties that the drug offers. This is the common thing, and this is where it stands out. So that's our idea, that it gives us, it's a hugely powerful tool that we have and can use it in our regular clinical practice.
A very simple thing which we notice, which I notice in my practice, and is because sometimes we will see some psychotic eruptions like this. Warts also we can yield it with selected medicines like Tuja, Sabena, Caustic, or something like that. Whichever is suitable, we can apply. We can correct it with the internal administration of potency medicines itself with these things. But while we are dealing with this skin tag and all, this type of psychotic eruptions, it is not due to any virus or anything like that. But lot of homeopathic doctors, I think, is trying to get rid of these things with medicines. What do you think? Is it possible or not?
Yeah, we do have some successful results with those skin tags, but we need to actually find what those skin tags are indicating and why are we having the skin tags. Now, if it's the dead remnant of certain things, it sometimes become pretty difficult. But while it's some part of an active process, suppose we said what we have an idea of sentinel piles or some dried up things, we would have a really hard time getting of these things. Then sometimes we do face patients who just have those skin tags around their nails. And sometimes it's simply because of some kind of an deficiency or some bad habits. So we can get rid of that with sufficient management. So that's the basic idea. So if we have known that whether this is a dead tissues that the tag is there, or whether it's connected to our vital parts, or whether these changes could be achieved, that also helps from our idea of what have been the pathology behind it. If it's not always that there's some bacteria or virus, but what have been the cause of having that skin tags? If we can find, obviously it happens that many a time we don't know, or we cannot elicit the cause due to our limitations. Yes, we have, obviously we do not have that advantageous positions, but then we have to depend on our clinical experience and what we have as our tools.
So we need to find out what we need to deal with homeopathic medicines and what not to deal. We want not to. If there is a big calculi. You mentioned about that. Through the ureter, if we need to pass it, the calculus should be that much. It should be logical also. Otherwise, it will be very disastrous if we are dealing that, and the whole system will get damaged due to this type of interventions.
Exactly.
And usually I also notice another thing. A lot of doctors which are very proficient in prescribing upon the pathological symptoms will be using a lot of medicines which are very particular to that specific pathological condition only. And they will be very proficient in that. They will get rid of these things. But according to homeopathic rules and principles, these things are just external manifestations, and internal correction is not possible by taking these things, and even suppression is being resulted. That is a thing, that is a no which homeopathic cardinal homeopathic principles place. And what do you think, sir, about these things?
Obviously, the basic idea is, even if we are going for the pathology, we should have that complete picture of these things. While there are some experts who would be taking just 3 or 4 symptoms and may construct all those things because they are just verifying those 2-3 things and can construct those natural history that, okay, this has been the probable history, this has been your constitution, this has my observations, and is fitting the cases. Probably in these cases, which most of us are not that proficient, just as I have heard, it was probably Dr. Lippi and the Kent, the famous story. They just visited the same patient. Dr. Lippi just asked the 2-3 questions. He had his answer. He wrote the medicine. And Dr. Kent, after an hour of case taking, appeared at the same medicine. So if that's the case, then it's fine. Probably we won't be having a suppression. But for the tendency of most of us, we always go for a shortcut. Okay, you have this sore throat. Let's give this medicine. It should work. It works in 90% of the cases, it should. And if we have this careless attitude and we then miss on something, or a chronic case, now this patient is having this recurrent sore throat, or a patient is having recurrent colic, we are giving Colocin, and the patient is getting well, and then again it's recurring. So if we do not go deeper, if we do not consider the totality, we won't be probably that Colocin case when the acuteness is subside, probably may be requiring Calicur or some other remedy. So we need to take that in action. So a reluctance, if it's from reluctance, probably it's a sin that we are committing. But if it's based on a fundamental and sound ground that we are having, as we have gone for this keynote methods, the so-called keynote methods, where we are having those pillars, which gives us we're asking just that 5-6 things, 2-3 things, and these 2 things are strong and sufficient enough to reflect the whole picture, then probably we are not deviating from having that totality.
Thank you, Doctor. And
I think Dr.
Time to conclude also.
Hand.
It's a great session, and we are having Dr. Dhanesh with us. I welcome Dhanesh.
Thank you, Dr. Bindaraj, and good evening, sir, SHIBASHIS MUKHERJee, sir. It's really a very good session indeed, and you really thrilled us with just like a one-day game, one-day cricket. That was that kind of powerful presentation it was. And we as from the presentation, what I mentioned, what I would like to add, that most of the patients are prejudiced, and they used to read all these things from the textbook, or sometimes in the YouTube, or sometimes. So they are coming back to us, and they are saying that they are started theorizing that this my condition is this and this is. But when we ask such a question, from when did you commence this disease, they may forget. But when you interact with them for a long time, they may say, "Oh, doctor, once it all happened as soon as my daughter was run away from her home, and she was married to a person whom we don't like to have. Such incidents are there in the mind, but when they come to the clinical side, they may say that it is a kind of my disease is peptic ulcer. So you have to treat the peptic ulcer. Doctor, I have consulted many physicians, and some of them direct me to the surgeon, and they told me that you have to undertake surgery like that. But only from the very simple question, we can understood what it is, what is the reason behind the illness, and when we get the illness cause behind the illness, we can definitely win the case. Am I right, sir?
Yes, sir. You're exactly, that's my point. That if we have an idea, like you have described that history, if we have that history, then we can probably move a step ahead to cure probably an additional age that others didn't have. So just yesterday, I had a lady who came to me that she is not having her stool, satisfactory stools. As a simple come, doctor, I have some problem with the bowel clearance. Okay, I do go to stool regularly. Some days it's clear, and some day it's not clear. So that's cited what could be the mistake. That is okay. Now the two ideas struck me. One, now this is a amoebiasis endemic zone where I live. So it could be some amoebic dysentery. And the second idea, that patient profile, a young lady around 27, 28, and she's preparing for something. When I asked her, what do you do? I'm preparing for jobs. So this could be a result of a disease, or could be a probable condition of a irritable bowel syndrome. That is some anxiety or some mental condition lacking behind. And on further inquiry, when I inquired, do you have all those things? Like, are you anxious about something, some problem in your family? The patient, how do you know that I have some problems with my family? So that's the basic idea, that what we know is we have this one step ahead, that this could be the probable problem. And depending on that, our approach would change. And we can go on to, if we have taken simply that patient is having this much problem, the stool is not getting satisfactory, evacuation is not happening. We may have missed it.
Thank you, sir. Thank you very much, sir.
Thank you for your patient listening, and I hope I have added some value to you.
Yes, sir, definitely. Thank you very much, SHIBASHIS MUKHERJee, sir, for an excellent session in this evening. On behalf of IFPH, as well as on behalf of the person who attended the seminar, and all of all the members of IFPH. Thank you once again, sir. Hope we can have some more presentation.
Welcome. It's been a pleasure.
Over to Dr. Shaila for the Malayalam session. Thank you.
Oh.